ऐसे लेकर घूम रहा हूँ and very small here I can't there is no see the letter. Meanwhile we don't observe any other fullness. Can you just feel for spleen like was demonstrated just now? Go look at his face and you should do it in synchronicity with his respiration. This is the whole idea. You know, when you examine a patient with a very clear-cut hepatomegaly, it won't be like this. You generally find a very good liver. You can actually spend a lot of time, there's no problem. In a tender liver, it becomes difficult. So be gentle with it. Don't try to find out things simply because it suits you. A tender liver with this kind of a position is not likely to be malignant. You actually are very suspect it could be an inflammatory condition. Even if you rub your hand with some pressure, it's not going to work. Now the next thing is, we have palpated for liver, we have palpated for spleen. We don't see any other fullness anywhere else. We generally have felt for any specific lump all over the abdomen. The next step is percussion. Now what all you like to cover up in percussion? You see, the percussion is done if there is an obvious lump. One percussion part we have already done to look for the upper limit of liver and the lower limit of liver. What was the liver span like? Paris. So you like to then measure it. Come and measure it. Give him the instinct. This is the point where you got the upper limit. It's important, mind you, to describe a liver span. In patients with some problem with the lung or collection over the liver, below the diaphragm, the liver can get pushed and you tend to feel the liver is enlarged. It's very important to see the upper limit before you say that the liver is enlarged. Yes, that's it.
It's around
14 centimeters. Enlarged span or it's normal? 10 to 12 is taken as normal. 14 is enlarged mildly, that's what we thought. Nothing unusual about it. So we expect it to be that way. So you're not surprised, but it's important to mention. See, examination is about not only thinking about it and knowing about it, it's about talking about it. And talking about it sweetly, in a nice manner, so that you're able to communicate to the examiner, I know it all. Because in any case, you will continue to examine abdomen all your life, you will continue to do better only, unless you mean otherwise. It will continue to improve with palpation, and you'll tend to feel things even before they appear. And maybe you'll develop your own methods of palpating the abdomen. But till the time you have to appear in the exam, follow the standard protocol. One correct way of doing it is what is ideal. Not the only correct way of doing it, but one correct way of doing it is the right protocol. Now we've done the part of palpation, inspection clear. No problem there? Anybody who has a question? Deep there? Good.
So
Now if you want to, sorry.
why is the liver span, how liver span works?
You will actually know the enlargement of the liver. That's why liver span is important. By that, if indirectly you mean, you know the upper border. Suppose the upper border was 8th intercostal space, and this was the liver. Would you call it hepatomegaly? You would be worried. You would be thinking about something else. That's where liver span becomes important.
So what are the different methods?
Let's talk about one at a time. Different we'll discuss. But classically, this is the method. I think that's good enough for the exam. You should be able to describe one method of it. That's what we discussed. Some people like to use the 4 fingers to do the palpation, but I don't recommend that in the exam. You must stick to the basic protocol, which is what is the right way of doing it. What else would you like to percuss this patient for? Free fluid. Or any lump, which you would have missed out on palpation. Percussion is supposed to be a better method of finding out things which are hidden. Now, how do you look for free fluid? This is a very pertinent question, often asked, at least I always ask it. Now, you start from the Zephyr study. As I do it, part of it was tender here because that was liver. A part of it was dull here because that was liver. So I started from there deliberately for you to start thinking it's dull to begin with. So that's where I started. Now what would you do therefore if there was a lump in this side, on this side, you would be percussing on the lump to know about free fluid, which will confuse you. So as I go down, it's resonant, go all the way down, rule out the bladder. Or in women, uterus, or any other pelvic lump. And at the same time, find out the most resonant spot to be used as a reference point. If you have to compare white with black, look at the brightest white so that you can compare well. Now, for me, which is the best? 1, 2, 3, the middle one. Good. So this is the point which is resonant. Now I have a choice to go either way. But if there is lump on one side, I'll go the other way. Is that clear? Now I have the examination in mind, that's why I'm talking to you on this. Okay? Now, I'm going to my side. Resonant? 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 Okay. Now who's going to do it? Come, Shilpi. Just repeat what you did.
So first we go through the zipper to the umbilicus.
Hit the finger hard, otherwise you'll hear nothing. I had to make the last person listen. You could hear that? Yes. That's the noise you should be able to produce. You wouldn't like to go down? Oh, I did that already. Okay.
Resident.
2 hours. Present. Can I say free fluid is absent?
Yes.
I can't. But clinically, I would say I couldn't demonstrate. For minimal free fluid, you may have to do more things. And for God's sake, don't mention put sign. Because that would mean you put the patient in knee elbow position, a position you would hate yourself. And the $1 million question is, when he is in knee elbow position, where are you? So it doesn't really look the prettiest of sights and it doesn't really help. If that little fluid is there, you're better way of finding it out. And no examiner would be fussy about that little of fluid to get after your life. For minimal fluid, theoretically speaking, you can assess it by doing a per rectal examination also. But it's theoretically saying that's precisely what I'm trying to do. So you'd like to exclude free fluid by percussion method and be fair about it. There is no confusion in your mind. The patient has hepatomegaly, don't get free fluid from somewhere. Importantly, don't listen to people who are trying to help you in the exam. Because they read it out of the notebook, the examiner is not read it. You will just see what you can demonstrate. If you can demonstrate it well, perfectly fine. Please sit down. Then you would, you percussed. While we were examining the abdomen, we had already seen the flanks. Now some people like to do the renal angle examination in inspection, some people like to do it in palpation, but it's much better to make the patient get up only once. Because renal angles should ideally be examined in a sitting position. That's how you're able to see them well. In a lying position, you can't examine them properly. In any case, no abdominal examination is complete without per rectal examination and examination of the spine. For per rectal examination, if you don't put your finger into it, you have put your foot into it. Which does not mean that if you cannot put your finger into it, you put your foot into it. It is not going to be possible and it's going to hurt really. I mean the foot. So it's important to do PR examination in all these cases. Why should it be mandatory? Why should it be mandatory? Anybody? One person. You didn't answer when I asked you.
So because many of the manifestations of the interabdominal pathology, it's a gateway, we can find out.
Yes, it's a gateway. Don't be scared of it. It's a gateway, and you can actually get a lot of information about gut and peritoneum through the rectum. There's no doubt about it. I agree with you. Once your examination of the abdomen is over and you're not doing anything, it's only human to cover the patients. Don't leave him alone and carry on with your exam. I know you're tense and anxious, but this gets you an extra point because they understand that you are a sympathetic individual. A very bright but non-sympathetic individual is worse than less brighter or more sympathetic individual. Everybody knows it. So the examiner also knows it. So much better to be kind to the patient. Now, coming to PR examination, what all information you can get in PR examination? Navdeep.
So in PR examination,
First of all, I'll cut it short. PR examination should be done in various positions. You can do it. One is Sims position, which is left lateral position. The advantage of that position is that it hides the genitalia. The patient's face is away from you. It also makes the examination of rectum relatively easier. I mean, it's a relative feeling. Some people like to do it in knee elbow position, but I don't think that's a very comfortable position for the patient. At the same time, genitalia don't get covered, particularly in women. So it's important to put the patient in left lateral position with the buttocks jutting out of the bed or the table that you have, couch, and ideally a pillow under it so that you're at the level of the anal verge, anal canal. We can't demonstrate it here. Normally, rectal findings are provided unless there is a rectal lesion. If you are examining a patient for PR, you're doing PR examination, what all information you're actually looking for? One, you would like to see if there is any fissure, fistula, abscess, naturally. You put your finger into the rectum after explaining to the patient that I am examining your rectum. And don't ask any points in history during PR examination, like do you smoke also? They can ask you, can you see the smoke coming up? So avoid that. Your part of history is over, you're basically on examination now. The patient is in left lateral position, with buttocks jutting out of the couch, knees flexed, hip is flexed, it touches the abdomen. Some people like to keep one limb extended, one flexed. I think there is nothing much in it. You can flex both. Patient is advised to breathe slowly, comfortably, like we did in the abdominal case. You can see he's sleeping nicely now. He knows he's in comfortable hands, although you see so many of you. The third thing is, apply the jelly nicely. Before that, a gentle massage on the sphincter relaxes. And gradually as you apply the jelly inside, the rectum or the anal canal is relaxed. You know, as soon as you get above dentate line, there's no problem. Below dentate line, it's a sensitive area. It's all somatic supply. So once you've applied it, you put the finger in with the pulp, which is likely to be literally looking at it. And then you go to feel the sacral hollow. You get an immediate feel of the patient's state of mind, the sphincter, the tone of the sphincter is known. Right? If it's very, very tight, if there's an acute anal fissure, you don't do a PR examination. Otherwise, the finger goes inside to feel the sacral hollow. Then you turn forward to feel for obvious things like prostate enlargement, you're not getting into that, any obvious growth. If you feel the growth, you'd like to know all about it. There can be a hepatic enlargement due to a carcinoma of the rectum. So don't think it's out of your mind. You should be thinking about it. Then you look for mucosa, whether it is freely mobile or it's stuck. Okay, clear? And then you feel for rectovesical pouch if there is any collection, or bloomer shelf as we call it. In women, pouch of pelvis. In men, rectovesical pouch. Be careful to use the word. You feel for any bloomer shelf or any growth, and then you bring your finger out, look at the color of the stools. If the patient has got an active bleed, or has got a melena, or the stools are clay colored stools or steatoric stools are suggestive of obstructive jaundice or pancreatic pathology, and black colored would be suggestive of melena, which is important. And examining the spine, you should ideally do with the patient in a sitting position or standing position, which is ideal. Now, taking better. Now, how do you look for renal angles? Paras? Pranjal? Anybody?
standing behind the patient, wearing.
You can ask him to hold his clothes. दोनों हाथ से पकड़ लो कपड़े. ये देखो. ये देखो. Always inspect and you will see the fullness. You can see any deformity of the spine simultaneously. Don't go as we discuss it. No, I'll examine the renal angles now, then I'll think about spine. No, it's all happening. Any visible deformity, paraspinal muscle spasm has to be observed. And then you look for the flanks. They look pretty all right. They're not full. Now what am I looking for in the renal angle? Any lumbar mass which was missed during clinical examination, unlikely, but you can feel for it. And also the tenderness in the renal angle, which is suggestive of stretching of the renal capsule. Now go ahead, how do you look for it? Where is the renal angle?
So it is bounded by the midriff and the
Erector spine.
So at this angle, after we inspected for any fullness, we wanted to jar with my thumb. to look for any
This is for any tenderness. Very good. You just jar it, don't dab it too hard, don't press it too hard. And you can feel both of them simultaneously. He's all right. And I don't feel anything which is dropped down. So there is no lesion. The spine looks all right. Seedhi karo kaman ekdam. Seedhi karo. Shabash. You can straighten it, and that makes the examination further easier because the muscle becomes taut. Erector spine is what keeps you erect. So you extend the spine and you'll find erector spine into business. The angle is between the last rib and the erector spine. Okay? And you may percuss the renal angle. He's right, absolutely. For
any operation of the
any obliteration of what? Isn't it supposed to be done? Now, when we talk about the band of resonance in front of renal lump or renal mass, we're actually talking about this band in front of the kidney. Usually it will be dull. That is if it is full. If it is empty, you can percuss, it will again be dull. So, all that is necessary and nothing that is unnecessary should be done. That's a Morrison's aphorism, old one for surgery that you do, for decision, for presentation that you do. Any questions pertaining to this patient? The case is not yet over. We end up by examining the left supraclavicular lymph node. The term left supraclavicular lymph node is a little confusing. Supraclavicular lymph node would actually end up being a posterior triangle lymph node. We are talking about a scalene group of lymph node. We are talking about Virchow's lymph node, which is felt between the two heads of sternomastoid against the scalenus centris. And how does it get involved? How does it get enlarged? Later. It clearly means the thoracic duct is involved. By whatever mechanism. If there is an involvement by gut malignancy, stomach malignancy as you mentioned, other malignancies, they travel along the thoracic duct and the thoracic duct joins at the junction of internal jugular vein and brachiocephalic vein. And this lymph node drains independently the same place. So it's a reflux enlargement of the lymph node. It may not be directly. And that's how abdomen is examined. Any questions?
So regarding the band of resonance in the renal angle, can you please explain that?
See, generally they say the renal lumps would be resonant on percussion due to the colonic band of resonance on top of them. That is if you see a lumbar mass and on top, where is, what's the relation of colon with kidney? So you feel it there, it's posterior post. So it won't make, that is not where you would percuss for it. That's a method of differentiating a renal mass from another flank mass.
Sir, can you put a pillow under the knees for slight flexion?
Absolutely, that's a very good question. Most people do that now. This would be up the middle part. You know, you don't keep it straight and you don't flex it totally. Keep it in between. So you can put a pillow there, it will keep it in that position. That is if you have a pillow. Examination of genitalia, hernial orifices has to be done again. I'm repeating it because it's important. A missing testis could be the cause of an abdominal mass. Don't think about tumor straight away. Missing testis can have so many other problems also. It can have inflammation, it can have torsion. Now does orchopexy improve or reduce the incidence of malignancy? So it's got nothing to do with incidence of malignancy. Detection is what is it. That's what it makes it.
Sir, how will we examine the rectophase in your lump?
Now, if the lump, we just discussed it about one aspect of it. If there was a lump to differentiate from parietal to intraperitoneal, that part, that's what I'm reminded of. if there's a lump in the abdomen and if it's in the upper part. Now I don't need to describe this as a lump in the right hypochondrium, which is moving on respiration, which is present in the right hypochondrium, which is exactly where the liver is. This can be described as hepatomegaly, but there can be another lump. Let's imagine a situation. Now if the lump is in the abdomen, you ought to first of all describe whether it's intra-abdominal or parietal. For that you can do a head raising test if it is above the umbilicus, or leg raising test if it is below the umbilicus. You all agree? No confusion? Now if you cannot do both, what can you do? You can do wall cell maneuver. In wall cell maneuver, the parietal lump would become more prominent, and intra-abdominal lump would become less common. Now that's simple. Coming to intra-abdominal lumps, they can be intraperitoneal or retroperitoneal. Most intraperitoneal lumps are mobile. Most. So they're free. Anything in the peritoneum has a movement, space, and retroperitoneal lumps are fixed. They move with the tilting of the patient's position. Intraperitoneal lumps. Don't try to put the patient in knee elbow position again. That is what one of the methods is. You start looking for whether the pulsations are transmitted or the lump falls forward. You try to put the knee elbow position. No. If on tilting the lump falls forward, it's an intraperitoneal lump. If it does not, it's likely to be retroperitoneal. See, remember, always is always wrong in surgery. Never is never right. So don't say always like that, never like that. This is not true. Generally. Clear? Now, if it is a lump too low down in the abdomen, don't describe its movement on respiration. It will be silly. Because lumps that are attached to diaphragm, or that are attached to lumps that are attached to diaphragm move. Gallbladder is attached to liver, which is attached to diaphragm. Spleen is attached to liver or to diaphragm, and if anything is attached to spleen, it will move. You understand what I mean? So don't describe a right iliac fossa lump. It doesn't move on respiration. It is not supposed to move on respiration, unless you breathe from the other side. The third thing is, if you have a lump which is fixed, it's more likely to be a retroperitoneal. Or even if it was an intraperitoneal lump, clinically it could have got fixed to posterior wall, and it's not going to move. In the upper part of the abdomen, if it is not moving on respiration, it's not mobile, it's likely to be a retroperitoneal lump. This is how you approach them. He didn't have that situation, but he brought it out. So that part should